Hello and welcome to this edition of Your Health, Your Wealth. I'm Dr. Eddie Patton, and I am excited to bring to you this podcast. My goal is to increase not only your mindset, but also your health set, and even your heart set and soul set as it pertains to your health and the healthcare system here in the United States. Today, we're going to be talking about the rising costs of healthcare, and we'll look at some factors that are contributing to that. First of all, when looking at the cost of healthcare in this podcast, hopefully you'll leave here with a little bit better understanding of the United States healthcare system. It is one of the most complex healthcare systems in the world, a large part due to the fact that it is regulated and costly. We could literally talk for hours about these different components of the healthcare system, but today I'd like to just give you an overview of some of the things, and in subsequent podcasts, hopefully we'll dive a little bit deeper into each one. I do want to start off by just saying that in the United States, I truly believe that we have one of the best healthcare systems in the world. We have physicians from all over North America, but all over the world that come here for training. The U.S. system emphasizes two main things, in my opinion. That's autonomy and choice as far as where you want to go. Patients can choose in general what works best for them, what facilities they want to go to when seeking their health care. However, there are some limitations to this. Of course, insurance networks being the biggest one, physician shortages being another. But for the most part, the autonomy and choice that patients have is one of the key drivers of the U.S. healthcare system. The other thing that we're really working hard on is making healthcare more accessible to patients. And lately, some things such as mobile clinics and telehealth have increased this accessibility so that people here in the United States can get the health care that they need, whether it be emergency services or whether it be cosmetic services or those immediate services that they need. So accessibility, one of those key terms that I think is going to be really important in healthcare as we move forward. Now, there are some limitations to this as well, but we're constantly looking for ways as the House of Medicine to increase the delivery of healthcare, make it easier for patients and more accessible. The ultimate goal is to place the patient at the key or the center of healthcare, and this model is one that really sets this healthcare system aside and lets it shine when you look at other systems throughout the world. However, one of the biggest flaws, and I'll use flaws in quotation marks, is really the cost of our healthcare system. And if you look into a lot of the research that's going on, one can question whether we're getting the return for the investment that we're putting in our healthcare system. When you look at infant mortality rates, maternal mortality rates, and so forth, we do lag behind some other nations when it comes to these things. And healthcare economists and those involved in the House of Medicine are looking at ways to make healthcare cleaner and to get those outcomes and the return on the investment that we're actually paying into healthcare. I want to just highlight some stats that comes from a paper that was authored by Spencer Delfino called The World-Class Innovation, but at what cost? A brief examination of the health care system in America. And listen to this. So the United States of America spends around $4.3 trillion with a T on healthcare in 2021. That's more than about $12,500 per person and makes up approximately 18% of the country's gross domestic product. The GDP is really the stat where we look at in our country the different things that we're spending on, what makes up the spending in our country. Now, the average GDP expenditure on healthcare for the 27 members of the European Union is less than 11%. Now you compare that to the 18% here in the United States. Germany, which was the EU's highest spender in 2021, they spent about 12.8% of its gross domestic product on healthcare, which comes out to an average of about $6,700 per person. Now you compare that to the EU's two lowest vendors, which were Ireland and Poland, who spent just 6.7% and 6.6% respectively of their overall GDP, which translates about $5,800 or $2,500 per person for each country. So looking at these stats alone and comparing the United States healthcare system to Germany, or really to a number of the other countries within the European Union, you'll see that we are spending and outspending these countries when it comes to healthcare. Even when you look at North America alone, Canada and Mexico, Canada spends about 11.7% of its GDP on healthcare, which comes out to about $6,000 a person, and Mexico spent about 6.2% of its GDP, or about $1,227 per person. So we're outspending even here in the United States, but are we really getting the return on that investment? And can we do a better job of increasing outcomes when it comes to this investment? Now, when looking at the total healthcare expenditures and breaking it down even further, of this multi-trillion-dollar investment that we're making into healthcare, America spends $1.25 trillion of its healthcare expenditures, again with a T, on administration. And when you think about healthcare administration, I'm not talking about office visits, direct patient care. I'm talking about all of the other things that go into healthcare, like prior authorizations, billing, claims, medical records, EHR. There are other publications recently that show that now doctors spend more time with medical records and doing things like documenting a visit than actual FaceTime with the patients. Now, in my opinion, this needs to be reversed. If we really want to improve healthcare, if we really want to improve patient outcomes, we should be spending more time with the patient and less time with things like documenting the visit or making sure that not to say these things aren't important, but the time value of what's needed, we really need to look at some of these percentages. So a fun exercise, which I initially I heard from a lecture years ago and did some more research on a much broader perspective. If you look at the U.S. healthcare system compared to other countries, there are some generalities that we can pull out. So if you look at the UK, United Kingdom, Britain, they have a national healthcare system. So the government essentially finances care and the government employs providers. Now here in the U.S., just their healthcare system basically looks like our system of how we treat the Native American population, military personnel, and our veterans through our Veterans Affairs Hospital, where we actually, the government finances healthcare and employs the physicians. Now you take Germany, for instance. In general, they have this, the government regulates not-for-profit insurers who in turn then pay private providers. Now here in the U.S., that's what most of our traditional insurance system for working people under the age of 65. Looks a lot like the system there in Germany. Now you have Canada. In Canada, the government finances care and pays private providers. Well, here in the U.S., that's a lot like Medicare or insurance for those over the age of 65 years old. And in other countries like Cambodia, where you get what you pay for in general, this looks a lot like our system here in the United States for the uninsured and how they get their health care. So this highlights the complexity of our healthcare system, where you can take all these different countries and their individual systems And there are some components within our system here in the United States. So it's a very interesting topic to talk about, to discuss, and to look at. So when we look at healthcare, the one thing that really adds to the cost is the fragmentation of the healthcare system. And by fragmentation, I mean the different sectors. If you think years ago, when a doctor, came to the house and on his horse, and he had his doctor's bag, and he would say, "Just take 2 of these, and I'll come back later, and you can pay him either with cash or money, or give him some eggs out the chicken coop, or some greens out of the garden." It was much more of a one-to-one interaction. But now, the true business of healthcare and healthcare administration has really dominated the field. At the base, though, the key component is still the patient-physician relationship. And that should really drive the whole system of healthcare. No hospital admission would take place without a clinician admitting that patient to the hospital, or a physician admitting that patient to the hospital. No drug would be prescribed without a doctor prescribing that medication. No imaging study like an MRI or anything else could be obtained without a doctor ordering that study. So this system is driven by, it used to be a physician's pen, but since everything is electronic health records now, it's really the physician's keyboard. So this system is driven by that. But how much are these other factors really playing into the healthcare system? And if you look at the different components, it's really interesting. So there's a document that came out in, I think it was around October 2021, that looked at the Medicare updates compared to inflation. And what's really interesting about this, we developed a term after this called a physician flatline. And I wish you could see this document, because when you see the graph, it really highlights, but I'll try to describe it in as much detail as I can. So in this document, you're looking at 2001 through 2021, and you're comparing the cumulative change in the different entities that make up healthcare during that time. And when you look at this data, Medicare physician pay increased just 11% over the past 2 decades, or about 0.5% on average per year. Roughly 1/3 of that increase was the temporary 3.75% update from 2021 that will expire in 2022. So for that 20-year period, the actual percentage of healthcare that has actually gone to physician has been flatlined, and even if you adjust it for inflation, has actually gone down. Now let's compare that to some other components in healthcare. Inpatient care, hospital care, both outpatient and inpatient hospital care. Medicare hospital updates totaled about 60% between 2000 and 2001, with an annual increase of 2.4%. That's doing better than inflation, which is measured by the Consumer Price Index, which went up about 50% over that period of time. You also look at skilled nursing facilities. This update, they increased by over 60% between 2001 and 2021. And the cost of running a medical practice, this is, in order to see your doctor, he has to pay rent. He has to keep the lights on. He has to pay employees. All of these things go into the cost of running a medical practice. These costs are measured in what's called a Medicare Economic Index. The practice costs increased close to 40% over this period of time. Again, just under the rate of inflation at 50%. So healthcare economy wise, if you were to look at this graph in whole, and if I were to summarize it, every entity in healthcare is doing as well or better than inflation, including hospital admissions, skilled nursing facilities, the cost of running a practice right under inflation, but actual physician pay when you adjust for inflation has actually decreased. Now, I am a little biased being a practicing physician, but as I mentioned earlier, as a driver, I believe in this system. Well, when we look at the cost of healthcare, it's important to look at those different drivers. And in subsequent episodes, we'll take each one of those individually. But in general, the rise in hospitals. Hospitals and hospital centers and hospital systems now have really taken a more prominent role in the healthcare system. They're now employing physicians. They are buying clinics. And in some markets, you see this consolidation where a hospital system may buy up several, let's say, primary care clinics or, neurologists, as I do neurology clinics. And so you have all of these doctors, your internal medicine, your family practitioner, your neurologist, your cardiologist, all within this hospital system. Now, that could be seen as a good thing because it helps to coordinate care. They all share electronic health records. But on the same token, when you look at consolidation, sometimes that model, particularly when you look at the economics of healthcare, may not be the best thing and truly give patients the best choice possible. Another entity that is really growing is the health insurance companies, the insurance industry. So the Affordable Care Act, which was enacted in 2010, it really expanded Medicaid. It created this health marketplace, among other things. But we've seen now a 38% drop in the total number of people who are uninsured between 2013 and 2021. But having insurance does not mean the same thing as having good insurance and having insurance that gives you the freedom and autonomy to see the doctors that you want to see. Those are two different things. And we'll dive deeper into the insurance industry in subsequent episodes, but that has been one of the highlights or the things that we've really discovered after the Affordable Care Act was passed, was that just increasing the number of people with insurance, it does not fully solve the problem of equitable health care to all, particularly in certain industries. We still have about 8% of Americans who are not covered by any health insurance at all. These are mostly cash pay patients, and it's a very interesting dynamic of how do we provide affordable health care for this class, a group of people. And the other caveat to particularly having a large proportion or a large number of patients without insurance is that there tends to be an overuse of emergency rooms and increased healthcare spending, because if you don't have healthcare insurance, you tend to wait until things are at their worst. We call this more catastrophic care. So you take a condition like diabetes, for instance. If you have a primary care physician, or if you can do those preventative things that tend not to cost anything, like walking, exercise, change your diet, watch what you're eating, you can reduce those severe complications of diabetes, like chronic kidney disease, like amputations, like losing your vision. So if we place the financial backing behind preventative care, it can decrease some of these high expense catastrophic care. And I can tell you that being admitted to the ICU or having a limb amputated because of a diabetic ulcer costs the healthcare system a lot more than if a simple sit-down counseling meeting with a patient and talking about the importance of diet and exercise. And so the switching the dynamic from high cost catastrophic care to more preventative, less expensive preventative care is one thing that we're really keeping an eye on and trying to figure out ways on how we can make this better. Now, the final driver in healthcare that we'll at least touch bases on today is the pharmaceutical industry. And the pharmaceutical industry has gotten a lot of press, a lot of coverage based on the cost of medications. But it's important to understand that the cost of drugs, the cost of medications that you see when you go to the pharmacy is not all determined by what the pharmaceutical company says that they're going to list the medication by. As a matter of fact, the pharmaceutical companies don't even take that responsibility of making sure that the pharmacies have the medications. The key is there's certain factors, a number of other players that play into this pharmaceutical industry that most people don't even know about, that lead to and have more of a determination on the actual cost of the medications. What pharmaceutical companies are responsible for are what's called the list price of a drug. So you put in the R&D, which is research and development, which, by the way, nowadays, for a lot of, particularly the big pharmaceutical companies, a lot of that money actually goes into just acquiring smaller companies that have developed some new or fascinating drug. We saw that with COVID, with particularly some of the antivirals. You go in and you find someone that's making headway, that's doing well, and you use your R&D to acquire that company, and then you have the market power to really put it out there in the market. So there's also sales. Once you've created this drug, you've done the research and development on it, you got to make sure that the word gets out there to the public. And getting into the whole discussion as far as generic versus other markets, that's a much larger discussion that we'll certainly talk about as well. But the pharmaceutical companies themselves have to make sure that these drugs get out there to the market. Now, that tends to fall on what are called wholesalers. And in the United States, there are 3 Fortune 25 companies that control 90% of the wholesaler market. And the goal of the wholesaler is so that the pharmaceutical company can focus on making drugs and all of that. They don't have to worry about how do I get these medications out into the community. So the whole wholesaler comes in and says, okay, we'll negotiate a price, we'll mark it up a little bit, and then we'll sell your product to the pharmacies to make sure that your product is accessible and available to the public. Now, more recently, if you've been paying attention to the news, some wholesalers have gotten involved with actually buying pharmacies. And that has created another interesting dynamic that we're really watching and need to pay attention to. And then the pharmacy essentially sells the drug and gets it out to the public. But that's not the whole picture. There are other entities like PBMs or pharmacy benefit managers that most people don't know who they are or what they do. Their job is basically to negotiate rebates with the manufacturers and create what's called tier systems so that within your insurance company, they decide, not the physician, but they decide which medications they're willing to pay for and at what rate. So when you take all of this into account, you'll see that the cost of medications is very dynamic. And it's a combination of both the insurance company, maybe the employers, and the PBMs, pharmacy benefit management, that all goes into this cost of the pharmaceutical treatments. So I know that this episode has been like trying to drink water from a fire hydrant, but I wanted to just introduce you to a couple of these concepts. When I really started diving into healthcare economics, some of these things like PBMs, I didn't even know existed. It's important to know, it's important to understand particularly as we have these conversations about healthcare costs and how to improve healthcare. In the end, I do believe it boils down to the patient and physician relationship. Everything outside of that should be there to support that relationship. The administrative costs that go into healthcare, I mentioned earlier, it's a very complex field. You have the government that's involved, you have insurance company now, you have employers that are involved as well. So you do need some type of administrative oversight. But how do we make sure that the proportion of administrative oversight is proportional to the healthcare delivery that we are delivering? These are the type of complex issues that we will continue to work on to make sure that we can get healthcare out to the public and make sure that it's equitable across different communities. So I hope that you will tune in for future episodes. We will, again, go into much deeper detail into each one of these entities, and hopefully as you pay attention to the news and listen to different things about healthcare costs and what goes into that, have a much better understanding of this complex system that we call the U.S. healthcare system. So thank you all for joining today and tuning into this podcast. Please subscribe to this podcast. If you want to learn more about what I do and who I am and my work, you can also go to my website, eddiepattonmd.com. That's EDDIEPATTONMD.com to see more. And I'm excited about this journey that we're going down and learning more about healthcare, not just healthcare, but the economics of what drives this system.